welcome to the Aural Apothecary podcast, authentic chat about medicines, pharmacy and healthcare in the UK.
Pharmacists Jamie, Gimmo and STC take on topical and controversial stories, but keep it edgy yet light-hearted.
Podcasts share their career-defining drug, song and book, and also share their joyful patient stories.
Welcome to the Aural Apothecary podcast. My name is Jamie Hayes. For this episode, we're joined by Dr Emily Reeve. Emily is a pharmacist and senior research fellow at the Centre for Medicines Use and Safety in the Faculty of Pharmacy and Pharmaceutical Sciences at Monash University in Australia. She is also chair of the Australian Deprescribing Network. We'll hear from Emily in a moment as she shares a drug for our formulary, her career anthem, and recommends a book for the Aural Apothecary Library. Our micro discussion this week is one of Emily's. What do clinical guidelines say about deprescribing? A scoping review. But first, let me welcome my two fellow apothecaries. STC is in Bournemouth and Gimmo is in Cardiff. Evening.
Evening.
Or g'day, I should say.
Couldn't stop him, sorry, listener.
Sorry in advance, Emily. So it's probably different weather to Australia here. So we've had a lot of rain. We had Storm Bert on the weekend, which just caused a lot of problems down here. So if anyone's listening who's affected by that, because I know quite a lot of people have been, then thoughts with you. I was driving in it on Sunday and it was horrendous.
So was I driving. Awful.
Yeah. So I spoke at the Behaviour Change Conference on Monday. It was the Public Health Wales Behaviour Change Conference. They run it every year. And so it was nice to speak. And my presentation was titled, Why Does Quality Improvement Fail? It was quite interesting because I was able to build on some of the stuff we talked about with John Seddon around we don't look at systems enough, but also that perhaps we're still not very good at considering human behaviour and using behavioural change techniques. And so actually was able to draw on quite a lot of the stuff we talk about in the podcast. So that was good. And I was in good company because the keynote speaker was, as you would expect, apothecary alumni. And that was Delith James, Professor Delith James. So it was nice to catch up with her as well.
Very good. I found myself in London on Thursday night last week at the Health Service Journal Awards. And there was an alumni there as well. Lely Obo was there. Her ICB was also put up for the Medicines Optimisation and Prescribing Award. But I'm very pleased to say that NHS Dorset won the award. So that was great. So it was a proper team effort. It was, the ICB, community pharmacists, general practice, and all about trying to a campaign to get patients to only order what they need. And so we had the graphics people there and the social media people, and there was even like big lorries driving around Dorset with these really good graphics about only order what you need. And so it was also time to sort of say, well, pharmacists shouldn't be ordering on behalf of patients unless they're vulnerable. So that was stopped. And then patients were lots of campaigns to get them to only order what they need. And so within the first month or so, they'd saved £500,000. They saved a load of carbon, obviously, in relation to stuff that wasn't needed. And so, and it's gone down really well. And in fact, lots of systems have already contacted NHS Dorset to take up the same idea. I think Scotland's been in contact as well. So, that was a very nice evening. It was a bit late, but it was great to be part of the team that won.
And that sounds a bit like there was a campaign in Wales that is still going on in Cwmtaf Morgannwg, actually called Your Medicines, Your Health. And it was a similar, I think their phrase was, take it if you can, tell us if you can't. Martin Davis was running that, and it sounds like a similar sort of thing, so I'd be interested to look at that.
Yeah.
And there are some photos circulating of the evening on WhatsApp, but we'll probably keep them to ourselves, Jamie, unless we need to use them at a later date.
Yeah, let's move on. Look, I attended this. I was chairing the Scottish Practice Pharmacy and Prescribing Advisors Conference in Glasgow, one of my annual gigs, and so Aural Apothecary alumni Tracy Brown and Jill Crickshank was giving one of the keynotes as well. Look, I picked up a few sessions. They had a Day in the Life series, so Remote and Rural by Katrina from NHS Highland was excellent. They did a day in the life of prisons. So Stephanie and Tuka from NHS Tayside, they gave a brilliant account of that. And then I went to a really excellent workshop on realistic conversations by Eleanor Patton and Claire O'Neill. I think Claire is a palliative nurse. I did show, and it was about 30 or 40 people in the workshop, I did ask for a show of hands of who has read Being Mortal.
Oh, yes.
And only our palliative care colleague was the one who put her hand up. So there was work to do for the people in that workshop. It was a superb workshop, but I was able to let them know that was essential reading. So yeah, great time in Glasgow. Excellent conference, 300 people, always a highlight.
Isn't that the conference that last time you managed to get us Tommy, who blew away the end of our series with an excellent episode last time? Is that correct?
Yeah, it's a recruitment exercise. Tommy Whitelaw and Catherine Labinjo, both recruited from that trip last year.
Very good.
Okay, let's move on. A great pleasure to welcome Dr Emily Reeve to the Aural Apothecary. We've done her bio on one of her university sites. It says Dr Emily Reeve, and then it has 4 words: deprescribing, polypharmacy, geriatrics, and dementia. Does that about cover it, Emily?
Hello, yes, that probably does cover my area of kind of expertise and interest, yeah.
Welcome to the podcast. You're our first Australian in 7 series. I don't know what's happened there. So we're international, Emily. We go to over 60 countries around the globe. But just tell us about prescribing and therapeutics and deprescribing in Australia from your perspective.
Well, it's a huge privilege to be the first Australian that you've had on the podcast, and I hope that the listeners are enjoying my Australian accent and can follow along all right. So Australia's healthcare system does have a lot of similarities with places like the UK and other countries around the world, but I guess there are some unique aspects. We do have a publicly funded healthcare system, but we also have private healthcare that exists for some extras like allied health, as well as some hospital services. But we do have a national, what we call our pharmaceutical benefits scheme, so where people can access prescription medications for significantly reduced costs. In terms of polypharmacy and deprescribing, there are a lot of similarities, again, with what we're seeing in places like the UK, the US and Canada, in that the number of medications used by our population is increasing in general, and that we're having increasing use of what we call polypharmacy, which is usually defined as 5 or more medicines. And with that increase in polypharmacy and medication use, we're also seeing an increase in the use of what's called inappropriate medications, which the way I like to define that is just that the likely harms of the medication outweigh the likely benefits in the individual. So it can vary. A medication may be appropriate in one person, but inappropriate in another.
Thank you. You don't have direct-to-consumer advertising in Australia either?
No, yeah, that's a very important consideration. We don't have direct-to-consumer advertising, although, and I have some colleagues who work in this space, there are some, I guess, less direct ways that advertising can occur to consumers. And I should say, I guess the other thing is that most prescribing is done by medical doctors, by physicians, or what we call our general practitioners, which are our primary care physicians. We do have nurse practitioners, but it's not nearly as common as in other countries. And pharmacist prescribing, I would say, is probably in its infancy here in Australia. There has been some very recent changes that will allow prescribing for mild ailments, but that's actually still kind of in pilot stages. And a few of our hospitals do what we call kind of a partnered charting process, with pharmacists being able to kind of chart on the drug charts within the hospitals. But I would say, compared to I think I was reading about, pharmacist prescribing in the UK, which has existed for quite some time. We're very different to that situation here.
I mean, we probably don't want to get into it, but we did see a few Twitter spats about that, didn't we, a while back? Because I think we joined in, didn't we, Steve, with some of them?
Well, we should say at this point, so somebody that I know very well and I work carefully with in the Health Innovation Network under the Polypharmacy Action Learning Sets is an Australian pharmacist called Zoe Girdis, who spent a lot of time working over here in general practice, but then was back over working in Australia for a couple of years. And she was in a regulatory role with one of the pharmacy organizations, I think. And so she did give me some interesting feedback about, yes, the differences between, well, the ability not to be able to prescribe, for example. So as you said, Emily, so I've been a prescriber as a pharmacist for nearly 20 years. So
Wow.
I guess that just shows just how far behind Australia really are. I'm only joking.
Yeah, we're not behind, but I guess different. But there certainly is a lot of interest, but there's a lot of discussion. I think that there is what I would say is perceived as resistance, but I think we really just want to make sure that because it is a change, that it's done appropriately, and patient care and patient safety is really what everybody is kind of fighting for.
Of course, I'm joking, and we had to go through all of those stages ourselves. But I will give you a big plus, because I think I'm right in saying that Australia didn't, it might even have been you, but didn't an Australia researcher come up with the term that we now use, deprescribing?
Yes, it was not me. I would love it if it was, but yes, Australia does claim the first time deprescribing was used in the kind of health journal space was in an Australian pharmacy journal, actually. So they did coin the term. That was back in 2003. It did take a little while to catch on, I think, more widely. It was more around 2010, 2014, where the term started actually being used more commonly. But I do say that Australians were certainly early adopters for the word deprescribing, and certainly early adopters in conducting research that's focused on deprescribing. Now, certainly before the word existed, the concept always existed, and there's some fantastic research that we're building on, but the need to kind of focus specifically on, you know, the process, the barriers, how we actually achieve deprescribing safely has certainly, I think, grown out of Australia, but we won't take all the credit.
And almost as soon as you did it, Jamie was registering the domain, wasn't he?
Don't forget, listener, I have lots of deprescribing domains available for project work, purchase, a rainy day. Just get in touch.
It's interesting, though, because I don't know about over there, Emily, but people still don't like to use the word deprescribing. And so
they need to move on.
I know, because, you know, it is what it says, I suppose. But again, going back to, bigging up Australia, you had, I think it was from the Tasmanian Primary Healthcare, had some of the very early information leaflets to give to patients about, for example, how do you think about reducing and stopping your use of omeprazole, for example, for gastric reflux. So it was really, I think it was Tasmania, and also there was the Canadian one from Ottawa. But they've always led the way, I think, in relation to those kind of materials. Is that right?
Yeah, absolutely. So the Tasmanian Primary Health Group, they developed a number of guides for healthcare professionals on deprescribing a number of different medications, and I know they continue to work in that space, and they update them, and they've added some new ones, and they're really just practical, really kind of basic and direct, and really useful for practicing clinicians.
Practical and direct. Sounds very Australian.
So, Emily, I was having a look at your website. You're truly international with your collaborations. Just give us a quick list of, some of the collaborations around the globe.
Oh, that might take me a little while. No,
just countries.
Well, I actually had the privilege of, I went and lived and worked in Canada for 3 years, so I certainly have a lot of Canadian collaborations. I do collaborate with a lot of people in the US, across Europe, particularly Switzerland. I have some good collaborators there, Belgium, and I feel like Romania recently, I collaborated with a team from Romania, which was really interesting. So I think certainly it's evidence that deprescribing awareness is occurring across the globe. And I think there's so much we can learn. Because we are a relatively new research field and a growing research field, I think one of the privileges we have is we are all really connected, and we don't want to reinvent the wheel. We want to learn from each other, and I think that's what's really reflected in all of the collaborations that I've been able to have, is that we want to be learning from others, and we want to collaborate, and it's not very competitive. I mean, we all want to be doing the best research, and we know that to do that it involves working together.
Barbara Farrell and Lisa McCarthy are two other people, aren't they? That you're the sort of three to me that stand out for leading the research in this area. And I think you've worked with both of them, haven't you? Probably maybe when you were in Canada.
Yes, I have. And actually, it's funny you mentioned Barb because she is currently here in Melbourne with me visiting. So I do, yes, have the privilege of getting to work with Barb, and she certainly is a pioneer in the space of deprescribing, and Lisa McCarthy as well. They are fantastic researchers who I think are really leading the way in this field as well as other fields.
So is there any country that stands out or is doing something particularly exciting?
I mean, I would say Australia.
Okay. Yeah.
We certainly, I think, we are relatively a smaller country in terms of population. So I think we're, kind of doing quite well in that. And I think we really do take a progressive approach to try and learn from other fields, implementation science, health literacy, the overdiagnosis. We're definitely looking at kind of new things that are happening. We're doing a lot of clinical practice guideline development, although again, I will give the credit to the Canadians for starting that work and Barb and her team. So yeah, I would say Australia because of course I've got to support all my fantastic colleagues. The other really innovative thing which was done in Australia was a randomized blinded control trial of deprescribing, where they actually tapered and discontinued medications by putting them within other pills. So they blinded whether the person was actually having deprescribing or not. And that was really because we have this question always comes up of, well, what are actually the benefits of deprescribing? What are actually the harms? We know a lot about the harms of medication use and continued use, but trying to tease out the exact clinical benefits can be a little bit more difficult. So my colleagues who are actually over in Western Australia did this fantastic trial, which was able to really establish safety. So unfortunately, they weren't able to achieve the sample size that they wanted to. But it was still, I think, a really innovative approach to doing a deprescribing study.
So it sounds great academically, Emily, and you sound world leaders on that stage. What's the gap between the academic reputation of Australia and deprescribing and the reality of deprescribing by your clinicians? Yeah,
so I will say that there is general knowledge of the word deprescribing, obviously knowledge of the concept. Even when probably 10 years ago when I would go and start talking to pharmacists or doctors or nurses, some of them had heard the term, some hadn't, but as soon as I started talking about the concept, they were all supportive and on board. So I think our clinicians certainly have an acceptance and a desire to be deprescribing. The problem is just all the barriers that we have in practice. And I think that's probably the gap between research and practice at the moment is we're learning so much and we know so much from the research space. And we're even doing research around implementation to support deprescribing, whether that's implementation of guidelines or other tools. My mentor, Sarah Hilmer, who does work with what's called the Drug Burden Index, using that as a tool to help trigger deprescribing, but there's still that gap between implementation research and actually achieving it in practice. And it's because there isn't just kind of one barrier. And as soon as we develop a tool or a resource to address that one barrier, there's actually still a lot more. But we are seeing a lot more kind of continuing education initiatives in Australia, particularly from our pharmacy organisations, but among the medicine and nursing as well. So I think there's certainly of our clinicians an awareness and a desire to be doing deprescribing, but how we can best support them to do that is what the gap is still.
I think pharmacists are probably aware of it, and Steve, you may have a better view, but I don't know that GPs in general in Britain would be aware of the term, or am I wrong?
What, deprescribing?
Yeah, I think they are aware of it. And when I said earlier that people don't like it, I mean, I think the best description, I think it's in your paper coming up, but you just put brackets, reduce or cease, because that's essentially what it is, isn't it? And so, yeah, I think that people do know it, but I think, and then they think they overthink it. and as Jamie said, whereas actually it's relatively straightforward. And I do a lot of teaching on this. And yes, it's the confidence thing and all those barriers that you talked about, Emily. But some of the better terms that people like is, have a drug holiday. Shall we suspend this medication? Because it's more language so suspension is seen as a neutral act, isn't it? When you think about suspension in a HR personnel type. So we talk a lot about the use of language, and generally people steer clear of deprescribing for that very reason. But I'm still going to give Australia coming up with it first in the literature.
I think there's a difference, isn't there, between being aware that we need to stop drugs and the problem of polypharmacy, and deprescribing almost as a discipline and an activity that you have to pursue with a separate plan. I suppose that's what I mean.
Yeah, and I will say I do agree there are some people, some clinicians that don't like the term deprescribing. They either don't think we need it, they think, well, it's just part of prescribing. Good prescribing, and if you go back to the WHO Guide to Good Prescribing, it is the final step. I've also heard some clinicians who feel that it's a very accusatory or very negative term because, you're saying that I did the wrong thing with prescribing. And that's not what we're saying at all. And I also think that there is a incredible use of having a term that is specific. Because while we do often describe it or define it as just, reducing or ceasing or withdrawing, a lot of those words are really non-specific. Discontinuation, stop, cease. There's also a lot of them. And many years ago, actually, we did a review on the term deprescribing and how it's being used. We found quite a lot of variation, particularly whether it includes dose reduction or not was a little bit controversial at the time. And we tried to frame it as a positive term and we talk about the process, because we know that achieving deprescribing is a lot more difficult than just not prescribing or just telling the patient to stop. So we do, usually when word count allows in articles, that's often why we end up shortening it. When word count allows, we often do say that the definition is that the deprescribing describes the process of discontinuation or dose reduction of inappropriate medications, and that part is obviously very important. And then the last aspect of the definition that's very important is that we do say that it's supervised or done in collaboration with your healthcare professional, because we do want to encourage that it does need to be a discussion with the healthcare professional. We certainly are not encouraging people in the public to go, I don't like this medicine, or I'm getting a side effect from this medicine, or I'm on too many medicines, so I'm going to stop it. Because there are certainly some very beneficial medications, and so it really is something that needs to be done, shared decision-making with that healthcare professional.
I think you're right about the word being taken sometimes as accusatory. And in fact, I don't use the word inappropriate anymore either, for the same reason. I tend to use the word suboptimal. But I think what's happening, certainly in practice over here, and I think elsewhere, and I've seen big reports in America, is it's actually now focusing it towards the public and saying, perhaps we're doing more harm than good, and therefore, and we've had a similar report in the UK, and so actually we're trying to encourage the public to ask for a medication review, and therefore it's a bit like the innovation curve. We're going to bring the people who aren't the early adopters along, because all of a sudden everyone's talking about it. So they might not use the term, but this idea that it's a shared decision between the clinician and the patient is really, I think, the key to how it snowballs.
Absolutely. And when we started doing deprescribing research and talking to some of my colleagues, we would hear what was the clinicians say, well, I want to stop the drug, but the patient doesn't want to stop it, or their family member doesn't want to stop it. And so actually the very first research project that I did was to ask patients. We developed a questionnaire called the Patient Attitudes Towards Deprescribing Questionnaire, which I think at the time we thought, this will be great. We'll just collect it in our sample and we'll have some good idea. And it's actually been taken off. It's been requested for use, and in fact is responsible for a lot of those international collaborations that I mentioned, that people are repeating using this questionnaire in their own populations. But we find that about 80% or more than 80% of when you ask, the public, would you be willing to stop one of your medicines if your doctor told you it was possible? they agree. They actually want to be stopping their medicines. So we think there's a bit of a perception of doctors think that patients don't want to stop their medicines. So yeah, certainly that in terms of overcoming that barrier, there is this interest now, as you said, in terms of let's be, educating the public, the population more broadly, that you can ask your doctor, hey, do I still need to be taking this?
That's what my public sessions are all about.
Yeah, I was going to say, listeners to this
Fantastic.
podcast will know that we talk about that all the time. And if Jonathan Underhill was here, the fifth apothecary, he'd say it's all about having good conversations.
The Aural Apothecary is sponsored by Jamie Hayes Executive Coaching and OneLessPill.com.
Okay, we'll come back to this, I think, when we do the micro discussion. But for now, Emily, you get to give the Aural Apothecary podcast 3 things as a guest. Obviously, a privilege for you to be on. And so hopefully you've prepared for this.
In case you're wondering, Emily, it is a privilege for you to be on.
I definitely think it is. Thank you.
So the first thing is what we like to call a desert island drug. And so this is a medicine that evokes a powerful memory for you. So it's not about saving you on an island. It's something that if you've ever listened to Desert Island Discs, where they pick 6-8 pieces of music, those pieces of music are intended, they're very personal. So what would you like to offer the Aural Apothecary Formulary as your desert island drug?
So I had to think about this one. I work in the field of polypharmacy, and so my initial thing was, could I say all the drugs?
Polypill.
Polypill, having all the medicines. But then there actually is another one, and that is proton pump inhibitors.
Okay.
The reason for that is actually in my final year of my pharmacy degree, I did an honours project as part of that. And you may be surprised to hear, but my honours project was about the solubility and stability of omeprazole in paediatric formulation. So I actually spent a couple of months in one of our wet lab spaces using a rather old HPLC machine, which involved, having to put up my samples.
High performance chromatography.
Yes, yeah. So using a pipette and putting a sample of the drug into the machine, and then having to wait, I think it was 12 to 15 minutes for the machine to do its thing, and then the paper coming out and the pen would come and then do this like peak, and then I'd have to measure the peak. And so I was looking at omeprazole, which is a proton pump inhibitor, and I can say that experience really helped me learn that lab-based research wasn't for me.
Yeah, I knew you were going to say that.
I have a lot of admiration for all my lab-based colleagues. But then, interestingly, I came back to PPIs when I started my PhD, which was focused on patient-centered deprescribing, and we'd done some work, as I mentioned before, about finding out how patients feel about deprescribing, barriers, enablers, developing a patient-centered deprescribing process. And then we thought, well, we've got to test this out. Which drug class shall we use? And we went, proton pump inhibitors, PPIs. We know they're overused. We know they're used inappropriately. They do probably have these harms when they're used long-term. And there was also kind of a thought of they're the low-hanging fruit. They're kind of the easy one. So we developed kind of a guideline, a protocol for kind of deciding whether it was appropriate or inappropriate. And we conducted the study out of a multidisciplinary, it was called the Multidisciplinary Ambulatory Consulting Service, but it was known as the Polypharmacy Clinic, which I think was a much more accurate name. And so we started screening people who were on PPIs to determine if they were suitable for deprescribing. We did this pilot study of deprescribing PPIs. Now, again, it was maybe a bit more complex and complicated than we expected. And I think that was the point that I learnt, or maybe reflected, that, hey, this deprescribing thing is maybe going to be a bit harder than we think it's going to be. It's maybe going to be a bit more complex. And one of my PhD supervisors still likes to say that it was kind of one of the most important studies that he's done. But we actually only ended up starting deprescribing in 6 patients, and we only actually ended up managing to deprescribe in 3 of them. So it doesn't seem on the kind of at that level that it was a very successful study, but I think it was successful in everything we learnt trying to do that. So I kind of went from lab-based, looking at a pediatric formulation, to health services research in the geriatric population, but both of them had a PPI.
Very good.
I did 3-dimensional chromatography when as my final year project, which I have fond memories of. But I didn't want a career in it. But also, I think I'm right in saying my first job as a GP practice pharmacist was reviewing PPIs. It was what we were all doing in them days, wasn't it, Jamie?
1996, I was reviewing PPIs.
Yeah, it would have been around a little bit later, but around the early noughties.
Well, this is unbelievable. I was checking while you were talking whether or not we've ever had a proton pump inhibitor for listeners, where your omeprazoles, your esomeprazoles, your lansoprazole. And guess what? This is a first pick.
Excellent.
Fantastic.
Yeah. So well done.
One of the world's most popular drugs, isn't it?
Exactly. So I was quite surprised when I was reading. Yeah, we've had ranitidine and cimetidine, the H2 alpha blockers. And again, we've had a few people pick where they've done a PhD or they've done some lab work. But that's the first time that we've had a proton pump inhibitor, and a great choice for a deprescriber, because, as you say, sounds like an easy win, but actually, wow, you get rebound if you just stop it. So you're going to need to wean, and you're going to need to do it slowly. So that's a great choice. Excellent.
So first for chromatography as well. Let's not forget that.
Oh, first for chromatography, yeah. So omeprazole goes into the Aural Apothecary formulary. Okay, the second thing that we're after is a piece of music for the Aural Apothecary Spotify playlist. And just because we might have some new Australian listeners, it really is on Spotify. So what would you like to offer? It's very, very eclectic. I think we're up to, this will be the 74th track. I think that's how many episodes we've done. You'll find them all on the website. But what would you like to offer the Aural Apothecary Spotify playlist? And why?
Yeah, so I don't know if this would already be on the list. I suspect maybe not. So it's a song called Shake It Out by Florence and the Machine. And it's this really beautifully haunting sound to it that manages to make you both emotional, but also I find it really uplifting as a song as well. And essentially kind of the message behind the song, it talks about kind of, there's a lot of negative things that can happen in your life and things in your past that can really bring you down. But the only way to kind of move forward is to kind of to look forward, to not dwell in all those things. And when you asked me to find a song, I thought of this one because I thought that maybe there's a little bit of an analogous and maybe it does really represent my career in research, in that there is a lot of, I guess, rejection that you get, a lot of difficulties, a lot of barriers you come up against. You get your articles rejected, comments from reviewers can be really harsh, you don't get the grants. There's competition. I've been about to publish an article and then you see somebody else, it gets published a week before you and they've done exactly what you've done, and it can just be really disheartening in a way. And this is something we often talk to our students about, and that being an academic researcher, there is a lot of kind of negativity and disappointment and rejection that you have to deal with. It is just a part. Even in the most optimal kind of collegiate circumstances, there is just still a lot of rejection because of that competition for publications, for grants, all of that. But you can't dwell in that. If you get so stuck focusing on things that you didn't get or other people got, and how rude this reviewer too was, as the joke is, you can't move forward. So I think it was only through you asking me to think of this, to find a song, but I think maybe it is going to become my anthem moving forward. Anytime I feel a bit stuck or I get bad reviewer comments, I might put this on and just there's a line that says, it's hard to dance with the devil on your back. And so it's kind of about pushing off all of that and kind of moving forward and dancing, which I like.
So great anthem, Emily. At this point, I need to bring in a new advert for the Aural Apothecary. Gettingpaperspublished.com. Check it out. It's my latest advert. It's my Getting Papers Published course. I've been a trainer for 12 years on it. There's not many trainers left now. It's based on a concept by Tim Albert. Have a look at the website. But it fits in with all you've just said about the angst about getting published.
Very good.
Didn't Matthew said something very similar last week? That was his choice. He said it's uplifting because being an academic can be hard. He said something very similar.
Yeah. And that's funny, like you said, the joke, the in-joke, I'm very green, but I still work at the University of Manchester and edit one of the European Journal of Hospital Pharmacy, so looking for reviewers. And yes, sometimes a reviewer too can be cutting. But anyway, so you've given that a lot of thought, and that's a great tune. I know that tune very well. So Shake It Out by Florence and the Machine will sound great on the Aural Apothecary Spotify playlist. Okay, and the third thing is something for the Aural Apothecary Library, and this is a book choice that you'd like to recommend to the listener.
So the first book that came to mind is the book you actually mentioned earlier, which is Being Mortal.
Yes.
Somebody working in geriatrics. But I saw that a few people have already mentioned it, so I thought, what could be something else? What could I add? And this one might be surprising. It's actually nothing, the book's nothing to do with health,
Okay.
but it is a book called Curlews on Vulture Street by an author called Darryl Jones. Curlews are an Australian bird. They're quite a funny looking bird. They've got long legs, kind of a big head, big eyes. And the book is actually kind of, I guess, semi-autobiographical. He is an academic in Australia who researches bird behaviour and particularly how birds interact with humans. And I actually only read it about a year ago, and it's become one of my favourite books, partly because I'm a little bit of a nerd and birds are something that I have more recently become interested in. But I think in relation to, I guess, myself and my career, he describes a lot of research that he's done at different phases of his career looking at bird behaviour. And there seems to be two things that have driven his research. One is pure curiosity of, why do birds do this thing? What do we know? And in fact, one of his very early projects, there was kind of a accepted knowledge about this particular bird called the brush turkey, and he observed something different, and all the senior academics said no, that never happens. And he's like, no, I saw it. And so he then kind of started his career with that. So certainly there's a little bit of, breaking the mold, not necessarily just going the status quo, which I think is important for all of us to think about in academia. But then the other thing that seems to have driven his research has just been there's a need. So in researching, birds and humans, it was one of them. There's a lot of these ibis birds that are within the city areas, and the city council didn't really like that. And how can we prevent these birds? The ibises in Australia, they are very lovingly referred to as bin chickens, and because they often in the cities you will see them in the bins. And so his research has been driven by somebody saying there is a need here, and so what can we learn and how can we then try to address that need. And as well as the book just being incredibly interesting, I think it does kind of inspire me a little in just kind of helping to remember why I'm doing my research, what is driving me, and that there is, and I guess for me, there is a need. We know that there is harm coming from medications, and we know that there is a need to help that. And so, yeah, as much as it's kind of just an interesting book, I think it does inspire me in a little way to just pursue those things. When those questions come up, when you go, hey, what's happening here and how can we help address it? Kind of coming at it with this curiosity, with this real desire to address this need.
Oh, that's brilliant. Has it got humour in it as well, that book?
It is, yes. It's quite funny, yes. So definitely, it's a good read.
What was it called again?
Curlews on Vulture Street.
So we have curlews in the UK as well.
Yeah, we do.
Yes,
Oh, you do? Fantastic.
Well, the current Mrs. Gimson is a Twitcher, so you may have just given me a suggestion for a Christmas present.
And when I asked about humour, I was going to ask whether or not it's Australian humour, because what we've been enjoying over here, well, I know Jamie and I have, is
Colin from Accounts, you're going to say.
Colin from Accounts. And it's a particular type of humour that we don't really have over here, but I've really enjoyed both series. So if it's anything like that humour, I'll definitely read it.
There definitely is a nice picture about kind of, because he grew up in a rural city as well, so learning about kind of rural Australia in the 70s is really an interesting reflection. I have to say, I think Australian and UK comedy senses are often quite similar. We like watching a lot of the UK comedians and things like Taskmaster and those things we quite enjoy over in Australia. Yeah.
Okay, great. Well, you've put a lot of thought into those trios, so thank you very much. And for any new listener, that's what this part of this podcast's original DNA was. Wouldn't it be great if we just asked people like, what's your desert island drug? What's your career anthem? What's your book? And so we made a podcast out of it. And stories about medicines. So great. Thank you very much.
Our micro discussion next. What do clinical practice guidelines say about deprescribing? A scoping review by Dr Veronica Langford and colleagues, including one Emily Reeve. What did you make of it, Emily?
Well, I think it's a fantastic paper to start with.
Tell me, before you do that, Emily, when I talk to people about doing presentations and things like that, I always talk to them about, we always have, and it's the same with podcasts really, we have 3 presentations in us and 3 podcasts in us. So it's the one we plan to deliver, the one that we actually deliver, and the one we wish we delivered. Is that the same for papers? The one that you plan to write, the one you actually write, and the one that you wish you'd written?
Absolutely. I think, whenever you start a study, you have this idea in your head of this paper that you'll have and what it will look like. And then, going back to reviewer 2 again, there's the paper that the reviewers wish that you'd written. And the paper that you end up writing to satisfy the comments of the reviewer, which is maybe not what you intended to write. And then, there probably is this idea of, maybe it's just like going back to the first one of like, I wish the paper could have been like I'd wanted it to turn out. But
It's fair to say, though, that this is in a high impact journal, isn't it? So we take quite a lot of our micro discussions from BMJ Quality and Safety because we really like the sorts of stuff that they publish. But it's good impact factor, isn't it?
Yes, it is. Yeah. Fantastic journal.
So perhaps you could just describe just very briefly to the listener, what you did and, well, more so what you found, I guess. We don't get too heavy into methodology, but you could say a little bit.
Well, I do usually start by kind of saying, well, why did we do this? What was the point of doing this study? And really was driven by, very early on is that healthcare professionals want more guidance to help support deprescribing. As we were saying earlier, there's this gap between healthcare professionals wanting to deprescribe but actually being able to deprescribe. And there'd been a few reviews previously that had looked at clinical practice guidelines and found very little in relation to deprescribing recommendations. And there were the deep drug-focused deprescribing guidelines that have been developed, but we know that it will take too long, too much money to develop a drug-specific guideline for every single medication out there. So realistically, to help improve the resources that are out there, one effort needs to be about integrating more deprescribing recommendations into all clinical practice guidelines. But then the other thing we'd done actually before this study was talk to some guideline developers about why they maybe would or wouldn't include deprescribing recommendations. And one of the things that we heard from a lot of them was that kind of the wording and how was going to be so important, and how do you actually write these deprescribing recommendations. So we set about with this review to actually look at, well, how have other people written these recommendations? What kind of information have they contained? What wording do they use? We were saying before, do they use deprescribe, stop, cease, withdraw, taper, discontinue? There's a lot of words out there. So we essentially tried to find what guidelines exist. What we found, we actually found more guidelines than we were expecting, to be honest. We didn't think there'd be that many out there. So we did find 80 guidelines. Now, keeping in mind this was internationally, any guidelines that were published in English, because we were focused on kind of the language and the wording that was used, but for any medical condition or any chronic medical condition where there are prescribing recommendations, so you would anticipate that there could or should be deprescribing recommendations. So while it was good that we found quite a few guidelines, when we got into what recommendations were actually there was certainly kind of a severe lack in terms of having comprehensive deprescribing recommendations that could actually be implementable in practice. So for example, there were a lot that were kind of just that said, don't stop this drug abruptly, or if the person's having this side effect, stop it or switch to a different medication. So there was some guidance there, but probably not enough in terms of how to actually comprehensively go about implementing deep prescribing in practice. And we know that if recommendations aren't seen as implementable, then they're not going to be. If they don't have the guidance on the how, particularly in relation to deep prescribing, they're probably not going to be implemented in practice.
I've got one question as a response, I suppose. It's right, and you said right at the start. The question is, do healthcare professionals have the time for more guidance?
So that is a very good question. And look, to be honest, when I was working as a pharmacist, if I had a question or I wanted to check something about a medication or an indication or a side effect, you're right, I probably wouldn't go and look at the full clinical practice guideline. I'd probably look at one of our kind of reference texts. We have the AMH in Australia, which is the Australian Medicines Handbook, or our therapeutic guidelines. But they are informed by these longer clinical practice guidelines. So clinical practice guidelines have an influence on, I would say, the culture of medicine, as well as other aspects that are happening outside of just a single clinician going and looking at this single guideline. So for example, we know that they're used in education. When I've done some teaching or tutoring, I will often look at the clinical practice guideline if I'm developing or preparing before giving training to, pharmacy students or other students. And so if those guidelines have, here's the prescribing recommendation, here's the deep prescribing recommendation, that may well influence increasing the amount of deep prescribing content in that curricula. We also know that guidelines are used to influence policy. And in places like the US, there are also what's called the pay for performance schemes, where if people act or prescribe or conduct tests that are in alignment with what's in these accepted clinical practice guidelines, they actually get greater payment incentives. So I agree with you that there are no, working clinician is going to be able to go and check these long guidelines, but they permeate, they have an influence on the culture of medicine and other things. Additionally, now in the age of we're moving towards electronic prescribing, having all these tools integrated, there is the potential for these guidelines to inform and be integrated within these clinical decision support systems.
It's a nice response, Emily. Thank you.
Yeah. Now, don't feel like we're ganging up on you now, but you're a bit unfortunate that the previous episode was a discussion about when guidelines go wrong. And Matthew Jones, who was the author, or one of the authors of the paper, and it was really fascinating because we got into really, I think, quite a discussion about, do guidelines stop clinicians from thinking? And this idea about, do you want to be too prescriptive or not prescriptive enough? And you talk in the paper about, should they be simple and digestible, for example. But I was really left, if I wasn't already thinking this, is that there is this issue, I think, about guidelines. So I agree that we need some form of guideline, don't get me wrong. But actually trying to think that we could have a guideline, as you say, to cover even all the main groups of medicines, even like proton pump inhibitors, but making them what I think you're suggesting is quite specific. I'm actually coming at it from the other way. And I'm not sure that that's the right way to do it. And I think what I'm really interested in is this idea that it's better to highlight that it's okay to think about deprescribing, but then in discussion with the patient, because they're all so individual, this idea of, well, tapering is a reasonable use of the term, because in some people reducing and saying that's reduced by 2.5 milligram every 3 days would be blatantly wrong. And so therefore, I think you're on a hiding to nothing if you were trying to cover everything with guideline. I hope that doesn't sound too negative, but that's what I think when I was reading it.
Yeah, look, and everything you said I agree with, but I will counter that in defense a little bit. And certainly I think the current situation that we have, where there are no or very little deep prescribing recommendations, I think that is a great example of when guidelines go wrong. And there was this seminal paper written many years ago by my colleague Cynthia Boyd around, if you take a hypothetical older 80-year-old woman who has 5 medical conditions, which is very common among older women or older adults, and you apply all the individual drug treatment guidelines to this person, they will have polypharmacy, they'll have drug interactions, and they'll have an increased risk of, falls, fractures, mortality. And so the guidelines, the way they currently exist, they're very focused on treating people with a single medical condition, but that's not reality anymore. So I see the need to introduce these prescribing recommendations as countering that issue of guidelines going wrong. I will agree with you that there is prescribing. We do say it is an individualized process, and when we have it's possible to have specific recommendations that still allow for that individualization. So it may say, here's a recommended tapering, but in situations where somebody's been on it for a long time or under certain, XYZ conditions, conduct a slower taper. We're also talking about having recommendations for how to achieve that shared decision making, or potentially it is just having recommendations that say, hey, think about deprescribing. We're still working on what is actually going to be most useful for end users, and a little kind of peek into some research that I'm doing at the moment is actually, we've done some interviews and we're doing some surveys with end users about what do they want out of those recommendations.
Excellent. That's what came out of the discussion as well last week about, user testing is so important. Go on, Gimmo.
No, I think I was thinking something similar to you in terms of, I think my conclusion in my head was you need a bit of both, don't you, in that it would be helpful within guidelines to have some advice on deprescribing for that individual drug or that condition. But also it goes back to what we talked about right at the beginning, is that deprescribing in the round is actually often a function of polypharmacy and aging, isn't it? And so when you're faced with that situation, the guidelines can't cover the complexity of what you might have to think about. So it's you need a bit of both. It's helpful, I think, to have some of that guidance related specifically to the condition, but actually the reality of deprescribing is it's a polypharmacy function.
Yeah. I mean, we've said this many times, but when doctors and pharmacists come on the action learning sets, and we've done nearly 1,100 people now, and they think they're coming on for a paint by numbers as to exactly what to do. And they get very sort of rudely awakened at the beginning to say that actually there isn't a painting by numbers for all of the patients that are in front of you. And it's about building confidence and courage to have these conversations, find out their values and preferences, and then go forward. So we are all agreeing, because at that point, you are going to need to, as a clinician, be able to point to something that would give you some advice and guidance about how you might go about it. So I think we all are agreeing. But I think the way that certainly in the UK we think about it is this idea that, and yes, if you could almost get, and if deprescribing is the end of the prescribing cascade, then we should all be thinking about in all guidelines, well, at what point should you should never say this is for life. In other words, you should prescribe it, say what the indication is, say what the review, when the review is going to be needed, or if and when that happens. So I think we are agreeing, but there's a risk if we think that we can guideline our way out of it, I suppose, is the way I'm putting it.
Look, guidelines are, it's not going to solve all our problems with deprescribing. Absolutely. We see it as one piece of the puzzle to help. As I mentioned, might influence education. It might be used for clinical decisions, like clinical decision support systems, maybe used by that individual clinician in that individual patient. But really, it's about anything we can do to kind of improve the culture of medicine. It also can signal that deprescribing is evidence-based. We don't always have the same level of evidence that we do for prescribing a medication, because there isn't the same level of money that goes into research that there is with prescribing medication, but there often is, and we often are surprised by how much evidence we do find, and that prescribing and deprescribing should be seen as both equally important, equally a normal part of care. And I think that right now that they're not. And so that's something that potentially these guidelines could help with as well.
Agree with that 100%.
And you mentioned a point in the paper, which I like, was like the incentive for the writers of the guidelines to do so. And I would say people writing guidelines aren't writing it with a view on how to stop it. They're writing it with a view of when to start it. And also their motivations might not, the evidence might not be there, but the motivations or their biases might not lend them to deprescribing in a way that we want them to.
Absolutely. And, having worked on a guideline, and I'm involved with a few others, deciding what to include in the scope, because doing guideline development as a comprehensive clinical practice guideline it's actually a lot of time, a lot of money. The more research questions you have, the longer and the more money it takes. So I recognize there does have to be a discussion of, if we're deciding to include prescribing recommendations, does that mean we don't have the ability to do other recommendations anymore? And they might be lifestyle recommendations, or something about prescribing or testing or treating. So it is a balance in getting them into the scope. But also what often happens is, well, these are the questions we addressed in the guideline last time, so we'll just be able to update our searches, do an update. And I guess we're hoping that when they're doing that update, we can say, well, here we've developed some resources or some guidance to help them then add that prescribing recommendation in.
Okay, thanks all. A big thank you to Emily for joining us on the Aural Apothecary, for getting up at 6 o'clock in the morning to join us for 7 o'clock, and for sharing her stories, her desert island drug, her career anthem, and her book for the Aural Apothecary Library. Coming up next time, we'll be joined by Professor Lauren Walker from the University of Liverpool. Lauren is a professor of clinical pharmacology and therapeutics and an honorary consultant in general internal medicine. She is also Deputy Director of the NIHR Clinical Research Facility at Liverpool University Hospital's NHS Foundation Trust, and co-director of the Centre for Experimental Therapeutics at the University of Liverpool. Join us next time on the Aural Apothecary. You can contact us via Twitter at Aural Apothecary. We're on LinkedIn. You can email us at auralapothecarypod@gmail.com. The website is theauralapothecary.com. Gimmo now with the final ingredient.
So thank you, Emily, and thank you for getting up so early, as Jamie said. Listeners won't be able to see, but instead of our normal glass of wine or beer, we all had a cup of tea. So this was breakfast cafe based chat rather than pub based chat, but it was great and it was a fantastic chat. So today's final ingredient asks the question: is it ethical to sell over-the-counter medicines that don't work? And so, to be honest, that's not a new question. Something that's been debated many times over the years when we're talking about things like vitamins, homeopathy, various cough and cold remedies. But the reason I mention it today is that it's a topic that's recently risen again with regard, and Steve, you might need to check my pronunciation because I've completely gone blank. Phenylephrine or phenylephrine? Phenylephrine, okay. So the question was recently asked on Vox.com, which is a US-based website, after a recent announcement by the Federal Drug Agency that phenylephrine is ineffective as an oral medication. So for those who don't know, phenylephrine is a commonly used drug in cold medicines as a decongestant, and Vox goes on to ask the question, why are so many useless cold remedies littering pharmacy shelves? The story is picked up in the UK by The Conversation, who reached a similar conclusion to Vox, and that was that national drug agencies only tend to remove products from sale as a result of safety rather than efficacy, and so it's not really likely that phenylephrine will actually be banned either in the UK or the US anytime soon. So is it ethical to sell them? I'm not going to answer that. It's too big a question, and perhaps one for another episode or our Christmas special. But in the meantime, if you do have a cold, hopefully I've just saved you some money.
You have been listening to a 3 Apothecaries production. Sound engineer Jimbo Slough, original music Jamie Brewster, artwork by David Baker and Jacob Howard.
Thanks for listening to the Aural Apothecary podcast. Warning, may cause drowsiness if you don't listen with caffeine.
This episode of the Aural Apothecary is sponsored by jamiehayes.co.uk.